Hello everybody, this is Alice Blue. This presentation is on interpreting lab results in clinical practice. Interpreting laboratory results is a core aspect of patient care and a vital skill for nurse practitioners to master in clinical practice. However, for new graduate NPs, this can be incredibly overwhelming and it can be a really daunting task. Many new grads feel that they're really unprepared for this major responsibility and often cite it as a prominent source of anxiety when they're transitioning from being an RN and a student to a nurse practitioner. There can be differing opinions or explanations for the results. So sometimes it's very hard to differentiate what's normal, why it's not normal, what you think, it means, what you need to do next. And it's okay to have questions and to not know everything. You just need to make sure that you understand that it's always okay to refer to your evidence-based guidelines, to refer to your, expert colleagues, because this is definitely a skill that you're going to hone over the course of your career. So for this presentation, we're going to keep it pretty brief. We're just going to stick to the most common laboratory studies that you'll see in primary care. These include the complete blood count with differential, comprehensive metabolic panel, lipid panel, thyroid function tests, hemoglobin A1C, and just a few others. Always important to remember, does the patient in front of you match the results on their lab report? Okay, let's get started. So the CBC with differential. This is one of the most commonly ordered laboratory tests and the most ordered test in the hematology lab. So it's the measure of the cellular components in the blood, the white blood cells, red blood cells, and platelets. It also provides additional information about the properties of the RBC. The erythrocytes, which are the red blood cells, they deliver oxygen throughout the body, and then you've got a little reference range there. We know it's higher in males and newborns and slightly lower in our geriatric population. Reticulocytes, these are immature red blood cells. They indicate bone marrow activity, and they only make up for about 0.5 to 2.5% of all red blood cells. We know that erythropoietin stimulates their production. This is a hormone that's made by the kidneys. You can see some abnormalities in polychromasia, or damaged bone marrow, which could be caused by cancer or in normocytic anemia. Hemoglobin carries oxygen within the red blood cell. The heme contains O2 and iron, which is the red pigment, and globin stands for protein. It's dependent on age and sex, and in males, you get a reference range, females reference range, so we see that in males it's typically a little higher. Newborns is the highest. Hematocrit, this is the packed cell volume. It's the proportion of red blood cells to plasma. It's used to assess the extent of a patient's blood loss. You've got a reference range there, again, a little higher in males. All right, so now we're going to look at some reasons why you may have a decrease or an increase in your RBCs, hemoglobin, or hematocrit. This is really going to help you interpret what might be going on and come up with a good differential list. So a decrease in your RBC, hemoglobin, or hematocrit can indicate anemia, chronic blood loss, acute hemorrhage, hemolysis, bone marrow suppression, or maybe a nutrient deficiency, B12, folic acid, iron, okay? An increase in your RBC, hemoglobin, or hematocrit can indicate polycythemia, hypoxia, high altitude, a smoking history. It's seen in cardiovascular disease, chronic lung disease, and in congenital heart defects. All right, moving right along, the RDW is the red blood cell distribution width. So it's the measure of anocytosis, which is the condition. The RDW is the red blood cell distribution width. It's the measure of the anisocytosis, which is a condition that causes red blood cells to be unequal in size. It can help you distinguish between iron deficiency anemia and thalassemia. You got a reference range, and then a high RDW basically indicates you've got more variation in size. The red blood cell indices, these describe the red blood cell morphology. Basically, are the red blood cells normal in size? Do they contain enough hemoglobin? And then they're calculated from using the RBC hemoglobin and hematocrit. And it's the MCH, MCV, and the MCHC. The MCV is the mean cell volume. It's basically the average red blood cell volume, and you've got normocytic ranges you can see. Macrocytic MCV equates to possibly megaloblastic anemia, vitamin deficiency, alcoholism, or it can be drug-induced. Microcytic or smaller cell volume can indicate iron deficiency anemia, thalassemia, anemia of chronic disease, or anemia of inflammation. And you've got to remember that small plus large will average out to be normal, so you can refer back to your RDW. The MCH is the mean cell hemoglobin. It's the amount of hemoglobin within the red blood cell, and it correlates with the MCV result. So the smaller the cell, the less the hemoglobin, the lower the MCH. You see the reference. And then your MCHC, that's the mean cell hemoglobin concentration. So it's basically the mean hemoglobin concentration of your red blood cell. Got an average there. The normal MCHC means normal chromic. If it's low, it's hypochromic. If it's high, it's hyperchromic. All right, these are just a few examples you can take a brief look at. They basically represent the different changes that you can see in your red blood cell indices and the types of anemia that they are referred to. And then you can think back to what causes those types of anemia to help with your differential and come up with
All right, moving along to the white blood cells. The WC is the total leukocyte count. There are 5 subtypes, all stages of maturity. When you have, let's see, there's your reference range. When you have a level that's above that, that's called leukocytosis. We see that often in full-term newborns, leukemic conditions, and then you'll see an increase in the total neutrophils with leukocytosis related to bacterial infection, tissue damage, inflammation. Leukopenia, or a decrease in white blood cells, common in viral infections, chemotherapy patients, severe infection, and then sometimes you can just see fluctuations that occur during the day. And so if you've got some levels that are very out of whack from what is usual for the patient, it definitely doesn't hurt to, not get too worked up. Let's go ahead and repeat it and see, if it's normal. Again, always make sure that, your patient and your lab match up. And if you've got a question, maybe a repeat is the best thing that you can do. Neutrophils are the predominant white blood cell in adults. You'll see changes with bacterial infections, phagocytosis. A left shift is an increase in immature forms of neutrophils. Lymphocytes are the predominant white blood cell in pediatrics. You'll see definite changes with viral infections, such as reactive lymphs, that's what they call it. Antibody production, lymphoid leukemias, and then sometimes you can see an inversion or a reverse diff. Monocytes, these are phagocytic. They increase with neutrophils and infections. They also change with chronic inflammation, and then in malignancies, you'll see some abnormals. Eosinophils, we know these as our allergic, component of our immune system. So in allergic reactions, asthma, you'll see changes, increases, parasitic infections, and then in CML. Basophils, these are the least numerous leukocytes. They will change in inflammatory responses. They contribute to the severity of an allergic reaction, and then you can see changes again in CML as well. The leukocyte differential, this can be done through automated form or manual. You get a 5-part differential. You'll get a relative and an absolute count, so you'll see a percent and a number, cell number. And then basically you use the total white blood cell and the relative counts to obtain the absolute values for each white blood cell type. And this should be calculated obviously for you. So I've just got a little example there of the relative values that you can see, and then a little image again with relative values and then absolute reference range as well. The absolute counts reflect the true increase or decrease that's seen All right, continuing our review, your platelets, we know those are the thrombocytes. They have a role in the cessation of bleeding. Got a normal reference range there. And then low platelet levels or thrombocytopenia, we know you have an increased risk for bleeding. I've got some possible causes or periods where you'll see thrombocytopenia occur. When do you need to worry about bleeding? So the concept of a safe platelet count is not really precise and lacks evidence-based recommendations. So it really depends on the disorder and on the patient. For surgical bleeding, generally, this is a concern if you have a platelet count less than 50,000 or less than 100,000 for some high-risk procedures, such as neurosurgery, major cardiac, or orthopedic surgery. When a spontaneous bleeding can occur if the platelet count is less than 20,000, especially below 10,000. Referral to a hematologist is appropriate to confirm any new diagnosis of thrombocytopenic conditions or to determine the cause of any unexplained thrombocytopenia. The urgency of the referral is dependent upon the degree of thrombocytopenia and any other abnormalities and the stability of your findings in your patient. Thrombocytosis, or an increase in the platelet count, there's a risk for inappropriate clotting, particularly in platelets greater than 450,000. We'll see your platelets increase in reactive thrombocytosis and signs or in conditions causing anemia, blood loss, infection, non-infectious inflammation, post-splenectomy, and more. Autonomous thrombocytopenia, it's caused by cell intrinsic mechanisms, mutations to genes, which regulate the thrombopoiesis. And so you'll see a lot of this in familial conditions, maybe inherited conditions, and then certain types of leukemia, CML, AML, and then MDS. So again, referral and further evaluation is going to be necessary if you see this in practice. All right, this is our last slide on the CBC with diff. So just to finish it up, troubleshooting factors that may lead to falsely abnormal values. This does occur, it can occur, it will occur. You're going to see this where you have a huge change in a patient that's very stable, asymptomatic. If this occurs, you may want to consider some possible reasons why, and of course get a repeat count. Hemoglobin, you can have a false increase if the tourniquet's on too long with hemolysis and with lipemia. And then the hematocrit, you can see a false increase or a false decrease. So hemolysis, basically, just so you know what that means, it's when the red blood cells become damaged and destroyed, making the report inaccurate. So again, you can kind of see how that could possibly happen during specimen collection. It'll falsely increase your hematocrit and your hemoglobin, and also it's going to mess up your potassium, magnesium, phos, your LFTs, all of that. Lipemia, this occurs when specimens are collected soon after you've had a patient that's had a particularly fatty meal, sometimes not even a super fatty meal, they've just eaten right before they've had their labs drawn, so they're non-fasting. So you have an increase in turbidity because of the accumulation of lipid particles. And so this can really mess up your RBC indices, white blood cells, platelet counts, and of course your lipid panel as well. All right, so this slide gets us started on the complete metabolic panel, or the CMP. These are just a few of the levels that you're going to see that come out on your CMP report. I included the reference ranges there, but these reference ranges are going to vary depending on the lab that's running the test. So, you may never see these exact reference ranges when you're out in practice, but it'll be something pretty close. And then you can just see the breakdown there of the CMP. What portion is, kidneys, electrolytes, your acid base, proteins, and liver. Okay, so these are the electrolytes and some common causes for why you may see some hyper or hypo conditions. So we know our sodium is essential for retention of body water by maintaining osmotic pressure and then your acid-base balance. You can see there that in times of hypernatremia, they may be caused by dehydration. You're basically concentrated, your patient may be taking high doses of sodium supplements in conditions such as CHF. If you have a patient that's been diuresed or that are on diuretics, or if they have impaired renal function. In hyponatremia, you can see that with SIADH, Addison's, again, impaired renal function, overhydration, okay, so it's diluted, basically, which all these conditions cause dilution, water retention, diuretics, and then losses during diarrhea and vomiting. Potassium. We know how important potassium is for cardiac and central nervous system function. It regulates the muscle and nerve excitability, and it's also important for glycogen use. And I just put a little, funny thing there, leg cramps. Everybody thinks when they have a leg cramp, it's their potassium. It's always got to be the potassium, which it may very well be in a lot of people. But in hyperkalemia conditions, that happens with renal failure, overtaking potassium supplements. These are over the counter. People can pick them up, start taking a whole bunch, not even really realize what's good for them, what's bad for them. And so always ask about that if you've got a new elevated K in a patient. Are they taking it over the counter? ACE inhibitors can cause an increase in your potassium level. Addison's disease, potassium-sparing diuretics, hypokalemia, malnutrition, decreased intake of potassium, alcoholism, diuretics, acute renal failure, and then you can have losses during diarrhea and vomiting. Chloride. Chloride is important for potassium retention, transportation of carbon dioxide, and in the formation of hydrochloric acid in the gastrointestinal tract. Sometimes you can see elevations in times of dehydration, multiple myeloma, kidney disease, and adrenal gland dysfunction. Calcium. This is important for endocrine function and neuromuscular function. It's influenced by the parathyroid and thyroid hormones as well as vitamin D. So if you have an elevated calcium level, this can be caused by too many supplements. Everybody takes calcium as they get older, it seems like. So, check your medication list, ask your patient if they're taking supplements. We can also see elevated calcium in renal disease from patients taking thiazide diuretics, when a patient has a bone fracture, malignancy for sure, hyperparathyroidism, and then with steroid use. Dietary deficiencies maybe, chronic diarrhea, if you've got a patient that has low albumin, and then in renal failure. Magnesium is not usually on a CMP. It's usually got to be ordered separately, I know for sure, in the clinic labs that I've used. So it's important for cardiac and neuromuscular function. Elevated magnesium can be caused by over-administration of magnesium supplements such as antacids, in renal disease, severe dehydration, and ketoacidosis. Low levels of magnesium are seen malnutrition, alcoholism, malabsorption, renal and heart failure, and then if you've got a low potassium and or a low calcium. Phosphorus. This is also going to be ordered additionally. It's not on the CMP usually. Sometimes it is. So just check your lab print off. If it's there, great. If it's not, you may have to order it separately if you're concerned about something. So it's important for neuromuscular function again, and the formation of ATP. Elevations can be seen with patient taking too many supplements, hypoparathyroidism, renal diseases, in acidotic states, and in laxative overuse. Low levels of phosphorus occur in burns, alkalotic states, diuretics, and acids, malnutrition, alcoholism, vomiting, diarrhea, and hyperparathyroidism. So you see a lot of these, reasons why you have low levels that are repeated again and again. So malnutrition, maybe they're not getting enough in their system, vomiting, diarrhea. Those are all ways that we can lose it and not absorb these electrolytes as good as we should. Glucose. So this is the primary source of energy for the tissues in our body. You see the normal reference range there, but it also can vary a little bit depending on your lab and of course depending on if you're fasting or non-fasting. When you've got elevated levels of glucose, obviously you're thinking diabetes, mellitus, could also be Cushing's, illness, times of trauma, surgery, or maybe an over-administration of glucose. It occurs with gestational diabetes, obviously, and steroid use. Low levels of glucose, possibly malnutrition, maybe liver disease, maybe an overproduction of insulin from maybe an insulinoma, or with medication. Albumin, this is a large protein in the blood plasma, and it's used to maintain osmotic pressure between the blood vessels and tissues. You can see a normal reference range there. In elevated albumin, you may be thinking the patient is dehydrated. Again, think maybe it's concentrated. Liver disease and renal diseases. A low level of albumin, possibly malnutrition, liver or renal disease again, burns, cancer, CHF, or maybe there's an inflammatory process going on. So we see albumin levels drop definitely with age. See a lot of low albumin levels in our elderly patients. You always kind of wondering, about them and definitely be thinking, are they having so much dependent edema, maybe because they're a little malnourished, the albumin's low, so the osmotic pressure is not being maintained. So just some little food for thought. All right, so this is the renal portion of a CMP. You can, it's going to come in your CMP, or you can order it alone in a renal function panel that'll also include a lot of those electrolytes. So the BUN, this is less useful marker for kidney function, and it can vary inversely with GFR. It varies with a patient's food intake, nutritional level, liver disease, hydration, and then you'll see it vary in heart failure. Slightly high or slightly low levels may not really have any kind of clinical significance. The creatinine, it'll vary by age, sex, and body size. Most labs will calculate your creatinine and GFR based on your sex and race. Let's say creatinine levels will vary due to production, variations in secretion, extrarenal excretion, and then issues associated with measurement can occur. A rise almost always indicates a drop in the GFR. However, drugs, diet changes, supplements, they can alter the creatinine production. So you may not necessarily see a change in the GFR, but you may see one in the creatinine, and that might be why. A normal GFR is approximately greater than 90 mils per minute. That's what, we're not going to be staging that as any kind of chronic renal disease. But a lot of, reference ranges will be, 130 for men and 120 mils per minute for women. A decline can signify progression of an underlying disease or the development of a superimposed problem, such as a decrease in renal perfusion due to volume depletion or possibly hypertension. It provides prognostic implications for staging or chronic kidney disease, which you should know the different levels and ranges for the different stages of chronic kidney disease. Okay, here are your liver function studies. They can be ordered alone as an LFT or liver function test, or they will come as part of the CMP. Your ALP, you'll see elevations of this that can indicate liver damage, maybe a blockage from a stone, or in bone diseases such as osteoporosis. It's very common to see an elevated ALP. The ALT will increase with liver damage or disease. And your AST, this can indicate, an elevation can indicate a liver or muscle, such as MI injury. You want to be thinking alcohol for an AST that's greater than an ALT 2 to 1. And if you also see an increased GGT. Total bilirubin and indirect bilirubin, you got the reference ranges there. This is a waste product that's processed by the liver. An increase may indicate that the liver isn't functioning properly. If you've got cholestasis, Gilbert syndrome, an absorption of a large hematoma, maybe that a patient had, that can also cause a transient increase. And then we've got albumin, a protein synthesized by the liver. Low levels can be a sign of cancer, cirrhosis, or malnutrition. I just added a few other levels here. There's definitely a lot more liver function studies that are done in hepatologists or GI offices, but we know that INR is important, and elevation can reflect a poor liver function, and it could be a sign of vitamin K deficiency, such as malnutrition or prolonged jaundice. Your GGT, if it's increased, be thinking possible alcohol-associated hepatitis. A marked elevation is common in cholestasis, and in other causes such as gallstones, cholangitis, sarcoidosis, maybe. So, a lot of, blockage basically of that bile duct, you're going to see some increases. It can also be increased in diabetes, gastric ulcers, and sepsis. So it's not necessarily always liver related. And remember, abnormal liver testing can occur because of disease, infection, drugs, and or pregnancy. Drugs include, you can read through those, so a lot of different things can cause an increase in your liver enzymes. Probably the most common that I see, obviously, are going to be our analipids, so our statins. That's why we always follow up with an LFT when we're initiating a statin drug with a patient. The hepatitis C virus screening is recommended for all patients born between 1945 and 1965 and those at high risk. And then in 2019, there was an update by the United States Task Force, and these guidelines suggest screening for HCV infection between 18 to 79 years of age. All right, so here's our normal lipid profile levels. You're always going to have a total cholesterol, an LDL cholesterol, which is your bad, an HDL cholesterol, which is your happy, you're good, your triglyceride level, and usually you'll have a triglyceride to HDL ratio. And so you've just got the little reference ranges there. Hyperlipidemia is so common. We see increases in times of obesity, and a lot of it is related to our culture, the way that we eat, our lack of exercise, our fast-paced lives here, where we don't really take the time to take care of our bodies. But there are some other possibilities for why you may see elevated lipids, especially if you've got someone like a marathon runner and they've got an LDL of 260. So basically non-fasting states, you're always going to see some elevation of triglycerides from normal, and the LDL cannot be determined correctly if our triglycerides are greater than 400. So if a patient's known to have triglycerides that are elevated when they're non-fasting, you really always need to require a fasting lipid panel on those folks. Otherwise, you're never going to have an appropriate calculation of their LDL. And they may even have elevated triglycerides when they are fasting. And it's important that you treat that triglyceride level, and remember that you're probably going to have a miscalculation of the LDL. There is a calculation that you can do yourself, but you're not really going to see that come up on many lab reports. You'll see an increase in LDL and diabetes mellitus, particularly when patients are uncontrolled. It could be heredity, it could be familial hyperlipidemia. In nephrotic syndrome, you're going to have an increase. Hypothyroidism, those patients tend to have a little elevation, a little to a lot. Pregnancy, the lipids can go up. Obesity, hepatic diseases, drugs can cause lipid panel to increase. You always want to treat the cause. So you may not necessarily want to slap a statin on a patient, okay? You always want to consider the whole patient, their history, risk factors for cardiovascular disease, of course, that needs to be calculated, and then, their lifestyle, the drug, alcohol use, any other chronic conditions that may be going on. When would you need to refer? When would you need to follow up? So most patients should have a repeat lipid panel with LFT once hyperlipidemia has been confirmed, and once they've been started on a medication or a treatment. Usually you're going to want to follow up with them in 6 to 8 weeks. You want to refer all patients that have homogeneous familial hyperlipidemia and all others with heterogeneous familial hypercholesterolemia or any other primary disorders with elevated LDL cholesterol who remain above their LDL targets on maximum tolerated doses of statins. So referrals, there are lipidologists, lipid specialists. A lot of them are, cardiologists, and they specialize in that. And they can do some other treatments that really aren't appropriate for us nurse practitioners in primary care. All right, now we're going to talk about the thyroid function panel. So what are the screening labs that are usually used to assess for thyroid function? Based on these levels, what does your patient have? Are they hyper? Are they hypo? A lot of students and new nurse practitioners can kind of get this backwards. So just, kind of a quick review. Screening usually is done with one or more of the following tests. It kind of depends on if you have a patient that has a family history, or if you have a patient that has, a lot of symptoms. It may not be so much of screening. Maybe, that you're looking for, you're doing some diagnostic testing. But screening, usually just TSH. We also use TSH for evaluating the treatment. Sometimes we'll also do a T4 in our hypothyroidism patients to evaluate their treatment. You're going to see some variation in the TSH, especially in the upper range. What is normal? Most labs goes up to 5 to be normal. You're also going to see some changes with age, and there's some controversy that exists on whether or not our older patients with a serum TSH level between 5 and 10 really require treatment, especially if their T3 and the T4 are normal. A lot of physicians, providers, they may say, this patient has hypothyroidism, even though they don't have any symptoms or signs or problems, and they want to just slap them on a thyroid medication. But we know thyroid medications are not without risks, and so it's really not appropriate just to put somebody on a medication based off a little elevation in their labs. You need to look at the whole patient. So free T3 and T4, those are both unbound and available for use and uptake into the cells and interaction with nuclear receptors. The bound hormone, or the total, that represents a circulating storage pool that's not immediately available. So if you've got a TSH that is elevated, okay, so you've got hypo, okay, your TSH is up, it's screaming to the thyroid, make more hormone, okay, so we're going to check a T4 if our TSH is elevated, okay, because we're going to be looking for hypothyroidism. I always want to repeat that TSH. Depending on how abnormal it is, I'll probably give the patient, a couple of weeks, maybe a month, and repeat it. So I'll get a TSH and a T4, okay? If the TSH is low, then I'm going to get a T3 and a T4 because that's what's useful to help me determine the degree of hyperthyroidism. So if the TSH is suppressed, basically the creation of that hormone is shut off by the brain, so it's not telling the thyroid to produce any more hormone because there's an abundance. When ordering labs to monitor levothyroxine therapy, I already pretty much said this, the TSH is usually only used. However, the free T4 can also be helpful, especially if you're determining if the patient needs to go up or go down, if the TSH is maybe a little high or a little low, okay, or if the patient's having symptoms. Primary thyroid disease accounts for about 95% of cases of hypothyroidism. So when you're screening TSH is elevated and you check the T4, with the TSH, if the TSH is still elevated and the serum T4 is low, then it's consistent for primary hyperthyroidism. If the TSH is elevated and the serum 4 is, or the free T4 is normal, then this can indicate subclinical hypothyroidism. And so the decision to initiate therapy can be case by case. Again, if the patient's not really symptomatic and maybe they're a little older, you really want to, consider, is this really necessary to put them on this hormone, and shut off their own body's production of hormone if it's really, the circulating levels are pretty normal. And so again, depending on your patient, there's a lot of studies that, contradict each other. So that's, got to be case by case and based on your patient. If the TSH is normal, but the patient has convincing symptoms of hyperthyroidism, then you can repeat the TSH and a free T4 to assess for possible secondary causes or central hypothyroidism. So central hyperthyroidism, that can occur with pituitary or hypothalamic disease. All patients with hyperthyroidism are going to have a low TSH. Serum T4 and T3 are required to determine the degree of hyperthyroidism, and patients with low serum TSH but normal free T4 and T3 should be considered for possible central hyperthyroidism, a non-thyroidal illness, maybe recovery from hyperthyroidism, or a physiological lowering of the serum TSH that can be seen in pregnancy. I just wanted to touch real quick on the possibility of a thyroid nodule being detected. You'll obviously have a TSH that's done. You're going to order a thyroid ultrasound and maybe some other serum levels if indicated. You can include the anti-thyroid peroxidase, or TPO, and the thyroglobulin. The TPO is helpful for diagnosing chronic autoimmune thyroiditis or Hashimoto's. So the TPO is going to be elevated in those types of autoimmune conditions. Thyroglobulin levels may be indicated in many thyroid diseases, including goiters, hyperthyroidism, and any other cause of destructive thyroiditis. You're going to see elevations. If you've got some nodules and you want to order a thyroglobulin level, an elevated level does not necessarily discriminate between, whether you got benign or malignant nodules. And when you get your thyroid ultrasound, basically there is a grading tool that radiologists use to determine the patient's risk and basically help you decide if the patient needs a FNA or fine needle aspiration to further evaluate the nodules, or if just screening maybe with another ultrasound in 6 months or a year is more warranted. All right, this is our last little slide. Most all of you know what a hemoglobin A1C is. So this is the glycolated hemoglobin measure that we obtain basically every 3 months on our uncontrolled diabetics. And we do that because red blood cells live for about 3 months, okay? And so it's going to tell us the average blood sugar over the last 3 months. Many offices have point of care testing, so you can discuss the results with your patient right then and there. So say you've got some glucose in the urine, or the patient's, peeing a lot, something to indicate, maybe they have diabetes. You can get that point of care hemoglobin A1C checked and discuss it with them, make plans right then and there. So you got normal ranges for hemoglobin A1C are 4 to 5.6. Greater than 5.7 to 6.4 is considered prediabetes. If I've got a patient that has a hemoglobin A1C greater than 5.7 but less than 6.4, I'm definitely going to be doing some education with these guys, okay? I tell them, you have prediabetes. Now is the time to set yourself up for success, to set yourself up not to end up with diabetes mellitus. So, you definitely need to encourage some diet changes, an increase in exercise. Basically, put them in control of their health, depending on the level and how much it, rose between the previous one that you've done. You may want to screen them again, do another hemoglobin A1C in 3-6 months, something like that. You may not want to wait a whole year. Just kind of depends on the case. And then we know if it's greater than 6.5, it's considered diabetes mellitus. If they have diabetes mellitus and it's less than 7%, then they are considered to be controlled. Less than 4%, this can be abnormal. It can possibly also be normal. I have seen some patients that live around 3.8, no symptoms, no problems. They've been worked up, and that's just kind of where they live. But if you see one less than 4, you probably need to be, discussing it with that patient, finding out a little bit more information, seeing if they've got any kind of family history, questioning them on, the exact signs and symptoms of hypoglycemia to see if maybe they are having symptoms and they don't really realize it has to do with their glucose. So you'll see this drop in insulinomas, basically where you've got a tumor on the pancreas and it's shooting out excess insulin, so it's converting that glucose and keeping those levels down. You can see this in NIP HS and in non-islet cell tumors, and then of course chronic overuse of any oral anti-diabetic medications. This can happen. So it can occasionally happen on patients that are super, super strict with their diabetes medicine, and then they also, make aggressive changes to their lifestyle. Their A1C may drop down, kind of dramatically. So it's always very important to start low, go slow with our patients, not give them too much medication so that they drop down and have any kind of hypoglycemia. So again, further testing may be warranted depending on the presence of Whipple's triad, which you can look up, and that basically helps you decide if the patient needs to be worked up further, or if it may be, that, everything's normal and that's just kind of where they stay. So that concludes our presentation. I hope you enjoyed it.